the marketing of these products. And we are extremely concerned about the aggressive and the inappropriate marketing followed by these companies that the code aims to restrict. So what was done? So again, it's a busy slide, but many of these points have already been covered. I'll only speak about what was done. So there was a desk review that was undertaken of the Sri Lanka Code by the Regional Office of UNICEF and global expert. And these were reviewed together with the Sri Lanka team and also validated at a workshop in Colombo. So what was done? The code was reviewed against, the code in Sri Lanka was reviewed against the national code to see how, to what extent the Sri Lanka law complies with the international standard and recommendations in the code. And this was done across the 7 areas that were identified in the code. As you can see, different scores were provided to each of these areas depending upon to what extent the provisions comply with the international regulations. And then based on total score, countries were grouped to and identified to be either substantially aligning with the code or moderately aligning with the code, or only where some provisions were aligned, or some countries didn't even have any legal provisions. So I'll, in the next few slides, share the findings of this assessment. But before that, just to caution that this exercise of scoring a law can be tricky, right? Because law is a very complex kind of a mechanism. So there were certain generalizations and simplification that was done when this scoring was done. And secondly, also we could not score all parameters. Only some critical parameters were used to compose these scores. So those were some of the limitations. And as I already mentioned, this is limited to the Sri Lanka Code, the legal provisions. It does not take into account the circulars that were later issued, and also doesn't take into account the more recent gazetted notification on the advertising marketing. So this was done as an exercise for all countries of the South Asia region, which composes 8 countries. Bhutan, one of the countries, did not have any legal provisions. It just had a guideline. So that was not considered. And you can see from the scores, Sri Lanka scores 69. So it is identified as to moderately align with the code. So let's look at this a little more closely. And across all the different 7 parameters for scoring against the code, we have seen the different scores that we have got on each of the areas. Let's look at each of them very briefly. And again, to highlight, what I'll be sharing now is I'll be focusing on what is missing, right? So there are many things that already the Sri Lanka Code is aligned to the international code. But those, in the interest of time, I will not discuss and repeat, but only highlight what is missing. So let's look at the scope of what is covered. I think Dr. Hiranya already mentioned, right? So the code in Sri Lanka was limited to age 12 months, whereas international code talks about covering the age up till 3 years of age. So this has already been addressed because of the updated guideline that Dr. Hiranya mentioned. However, what happens is when we have the code limited to 12 months, many other products, follow-up formula, toddlers' milks, etc., all of them get promoted. I mean, our companies are able to promote it, and there is a tendency to cross-promote products, right? So this is something that we need to be especially careful about. Then around monitoring and enforcement. So while the code in Sri Lanka identifies the ministry in charge for monitoring and also recommends regular committee meetings to review any violations that happen. However, the powers of the committee to investigate and prosecute are not specified in the code. The composition of the committee is not specified in the code. And the requirement that this monitoring and enforcement should be independent and transparent and free from commercial interest, that is not specified. And neither are the sanctions in case there are violations that are identified. So these are all some of the observations, but also these are clear recommendations for us in terms of what we need to do to strengthen the code further. Related to information education material in child feeding, what is expected is that while the formula products need to be available, right? So there will be some women who will require these when they are properly assessed and indicated. In those situations, appropriate communication has to be accompanied with that. And it is important that the code specifies what those information or communication should be about. An example, that when formula is prescribed or required, then it should be accompanied by a warning that there is a risk of contamination of the powdered milk that happens. And in the Sri Lanka code, we do refer that the manufacturers or the companies, they do not do communication or they do not communicate about the product, but this seems to be an absolute recommendation, which means that they should not communicate about anything, whereas we would want them to communicate about the risks of using formula. So that is something that our code needs to incorporate. Again, this is spoken about. Promotion to general public, we have scored full, but clearly because the coverage was up till 12 months, it led to continued promotion of the other products and the risk of cross promotion remained. Promotion in healthcare facilities, again, we have scored quite well. The only suggestion for further improvement could be to prohibit companies to use facilities to host events, contests, or campaigns. This specifically has not been adequately addressed. And engagement with health workers and systems, I think some of these provisions were not part of the code. They are, of course, I am aware that in the subsequent circulars by the ministry, many of these points have been addressed. However, it is important that in the legal provision as well, these points are specifically mentioned and highlighted. And finally, on labeling, extremely important that the claims, health and nutrition claims made by the companies on the labels should be prohibited. Now, these are all the findings that I wanted to share. Just to highlight that the code is an enabling tool for all of us to ensure that compliance to these by the companies is ensured and that we are in a position to be able to promote, support, and protect breastfeeding. And also to say that just having the code as a legal provision alone may not suffice. We would need the commitment from all of you, all of us who are here in this room, to ensure that this code is enforced and that we continue to maintain the very high and levels of breastfeeding that we have achieved as a country, and that we do not fall back in the coming time despite the crisis and the challenges that the country is facing. So I think a lot of many partners have helped in ensuring that this analysis is available for us to take this initiative forward, and I thank all of you for this.
Thank you, sir. It is with immense pleasure that we invite our key speaker today at today's event, Dr. Nigel Rawlins. Dr. Rollins joined the Department of Maternal, Newborn, Child and Adolescent Health and Aging at WHO in July 2008 and is a member of the Research and Guideline Development Team. He trained as a pediatrician in Belfast, Northern Ireland, and his work focuses on interventions to improve child survival, growth, and development. This includes research to improve the coverage and quality of infant feeding practices, optimizing linear growth of children, preventing child obesity and the risk of non-communicable disease, and the prevention of mother-to-child transmission of HIV with a focus on breastfeeding. Prior to joining WHO, Dr. Rollins was professor and head of the Center for Maternal and Child Health at the University of KwaZulu-Natal, Durban, South Africa, where he lived and worked for 14 years. He will enlighten us on the key points in protecting breastfeeding at a time of crisis.
First, may I say a word of thanks for the very warm welcome that I've received here in Sri Lanka. It has been excellent. It's been wonderful to be here. I thank particularly the colleagues, but I now consider friends, both in the ministry and also my colleagues in WHO and UNICEF. So I wanted just to say thank you very much for that. And for today, to be able to join you, I commented on Friday that I didn't like the word that I'm here to educate. I'm here to be part of the discussions and to learn along with you. And so I'm very grateful for that opportunity to do so. And I think in this room, there are all the different stakeholders that are really needed and necessary. It is not just the colleagues at the senior level within the ministry, but it's actually the directors and the hospital managers and people on the ground that are essential to involve in this discussion. I'm very conscious that Sri Lanka is in a time of economic crisis, and so forgive me because I do not know the realities of this every day. I have read about it and I have heard about it, but I cannot experience it from a distance. But I do appreciate that this is a very real phenomenon for everybody in this room and in the population. And it's in this context that we can absolutely say that infant feeding matters and that breastfeeding is crucially important. We've heard a little bit about the benefits of breastfeeding. And one thing that we can say is that the evidence around the benefits is very strong. We understand more and more about the human biology, the influence of breastfeeding on lifelong health and development, on maternal health, and most critically upon survival of young children. So I'm just going to show you 2 or 3 slides, and I'm not expecting you to read the data or anything. It's too small and from a long distance. The main message is that there is a body of high quality evidence behind all of our comments and statements that breastfeeding is a very, very valuable intervention for young children. We have done systematic reviews and modeling, and we see that if we were to increase breastfeeding practices globally, over 800,000 child lives would be saved every year. We know that breastfeeding has a profound impact, not only on survival, but on morbidity. It would reduce episodes of diarrhea. It would reduce episodes of pneumonia. The evidence is strong and present. The impact on hospitalized care would also be very, very significant. It's not just against survival and diarrhea and pneumonia. Breastfeeding protects health throughout life. It's important for protecting against type 2 diabetes. We see the burgeoning pandemic of childhood obesity, And breastfeeding is the single most effective preventive intervention with an 11% protective effect. We see that again in these systematic reviews, and we also see clearly today the impact on childhood development and intellectual performance at 30 years of age, and it has an impact. The problem in a time of economic crisis is that the timeline and the crisis is here and now today, and we do not really, we don't feel that we have the time to have these long-term perspectives. We've talked about maternal health, and the work that we've done on a series of Lancet papers show that each year that a mother breastfeeds reduces her risk of invasive breast cancer by 6% each year that she breastfeeds. It also reduces the risk of ovarian cancer. So it's not just the benefit to the child, but the benefit to the mother. Every year, breastfeeding saves about 20,000 deaths from breast cancer. And if breastfeeding were scaled up more, then another 20,000 deaths would be, amongst mothers would be prevented. And for those who are in programs and managerial positions, there's a very strong economic case for investing in breastfeeding. Again, the details we will not go into today. But when you look at the long-term effect of what breastfeeding contributes to childhood development, globally, it translates into $302 billion every year because of improved childhood development. And if you look at the effects on health systems, which is very real today, then breastfeeding reduces annual health care costs. Simply in the US, UK, Brazil, and urban China, it reduces costs by about 400 million on an annual basis. So that is a very relevant figure and value to be thinking about even during the immediate economic crisis. The strange thing is that despite all this high quality evidence for the benefits of breastfeeding, we see that over the past 20 years, breastfeeding practices globally, that fewer than half of all infants are actually fed according to WHO recommendations. Less than half. Even whenever we have this information and education, there is something that is not happening. So this is what we see. We see that exclusive breastfeeding rates, these are the lines at the bottom, the solid lines, are only increasing slightly. Continued breastfeeding rates, the dotted lines at the top, are about flat. Now, Sri Lanka actually does well in these numbers, but we've got to be saying that you cannot just sit where you're, at the moment and just say, take anything for granted. Because what we see is a global trend, and what we see on this graph, again, it's hard to see the numbers, but look at the black line, because on the horizontal axis, you have GDP per capita. So as you go further to the right, the individual within a country is getting better. And what you see on the vertical axis, one going up and down, is the amount of sales of formula milk. So as you go to the right, you see that there is more retail sales of formula. And we are seeing this all over the world. And this is not just the dollar value or the metric tons. This is per individual child. So as you are seeing economic development, you're having more sales per individual child. This is an analysis that we also saw within the Lancet. And for each doubling in national GDP per capita, you have a decrease at 12 months breastfeeding rates of about 10 percentage points. And this really asks the question, why or how does this happen? Part of it is probably because women are going back into the work environment and there is inadequate maternity protection. And the second reason that I can think of is that as the economy improves, there is greater disposable income at family level, and families are then the target of marketing. And so we see these two areas where we still need to promote breastfeeding and support it through maternity protection, but we also need to take cognizance of marketing. So we see the figures in Sri Lanka from 2016, which are, they are right up there in the very best globally. But you're in an economic crisis. And so it begs the question, can you actually increase your GDP without undermining breastfeeding? Can you avoid the trap that every other country has fallen into? Because there is an expression, never waste a crisis. And you can be absolutely certain that the formula industry is seeing this crisis in Sri Lanka and looking to the opportunities. And the question is, does the public health community also recognize this important time? So I just want to talk a little bit about marketing. There are many reasons why women don't breastfeed. Work constraints, inadequate maternity protection, perceived milk insufficiency. She doesn't think she has enough milk. There are many changes in societal norms, and I don't know all the circumstances in Sri Lanka. I can tell you from the research that we look at globally, these are the types of things that happen. Poor support within the health system is a critical one. The early initiation, the support for exclusive breastfeeding, are health workers giving a consistent message? And I'll come back to that a little bit later, but if I was to ask everybody in this room, the fact that you are here probably means that you are a supporter of breastfeeding. You believe in breastfeeding. And we undertook a survey in 8 countries. We interviewed 8,500 women and over 300 health professionals. All the health professionals said that they believe that exclusive breastfeeding is beneficial. And I'll show these numbers a bit later. But when you ask the mothers, where do you get your recommendations for formula milk? It is mainly coming from the health professionals. So we as health professionals, we say one thing, we believe this, but then we do something that almost contradicts that. And again, in a time of economic crisis where probably the salaries and the incomes of health professionals are also stretched and vulnerable, then the question is, what is industry doing to try to influence our behaviors? So, although there are many reasons at the family level or for individual mothers, work, etc., marketing is unquestionably an influence. So very often when we see the word advertisement, so these are some images from products in Australia, and you see the same name, the same images, and all they're differentiated by 1, 2, 3, 4. So these are products for different age groups. So in Australia, they aren't allowed to market for foods for infants less than 6 months, but they do it for the older age groups. And this is what we call cross-promotion, because they don't need to market for the young-aged product because they're marketing for the older ones. And this is something that we hear is going to be addressed in the updated food labeling in Sri Lanka. So that's a very good thing. But sometimes all we think about are these simple adverts. Here's another one. And where this image of the mother, the child, industry spends a lot of money, and they engage the highest and best marketing agencies and science to design the image in a way that is very engaging with the family. They put it on it inspired by breast milk research. What they're actually saying is formula milk is as good as breast milk. So it's the subconscious message that they are giving. And this is what they research. They don't look at the p-value of the epidemiology and the statistics. They're understanding what is the trigger to both health workers and to the individual mothers. And so what I think is that we have been guilty of is a very superficial and naive understanding about marketing. And there were a series of papers published earlier this year in The Lancet. And as part of that work, there was a framework developed. Again, it's hard to see from a distance. But really, it's very simple, actually. It is not complicated. What we see right in the middle is that the objective and the aim of all marketing, not just for formula milk, is to shape and influence the social, the professional norms and values and beliefs. Are we absolutely convinced? I remember asking whenever I was in South Africa amongst my colleagues, consultant pediatricians, and we had a room there was about 30 or 35 people. How many of you absolutely believe that breastfeeding by itself is sufficient for 6 months? And I'll tell you, my consultant colleagues were hesitant to put their hands up. They really weren't convinced that exclusive breastfeeding was sufficient for 6 months. And that uncertainty is all that is needed to translate into recommendations for formula milk. And what we see in Europe and North America and in other countries is a belief amongst families that giving formula milk is inevitable. It will always happen. It may not happen at birth, but it may happen at 2 months or 4 months or 8 months, but all children will be formula fed. That is the belief within communities and families in other parts of the world. And that is because there has been a slow process of influence. And this marketing is all about altering decisions in civil society, amongst health professionals, amongst families and communities. But it doesn't stop there, actually. Because I know that some colleagues would point and say, well, health professionals are the problem. But in fact, health professionals are simply a target. And your directors in this room of hospitals, the ministries and the secretaries, not just health, but in trade and labor, they are all targets of marketing because they influence how policies are developed, how tax is levied, and ultimately the environment within sales occur. And this is what we see. In 2018, the sales of formula milk were about $55 billion. And in 2019, a minimum of $3.5 billion spent on marketing. That's an absolute minimum because it doesn't include lobbying, social media, or the sponsorship of health professionals. And this type of money gives industry enormous power, and it enables them to actually take on sophisticated political strategies. They present a very kind and sort of benevolent face, but then they do everything to undermine regulations. So as you have your new regulations coming up, you need to protect every statement in the draft legislation. What we see globally is more and more of the normalization of public-private partnerships, of industry moving into hospitals to provide a service. But they are there for a reason. We see in Ireland, for example, where the lobbying companies for the dairy industry and the formula industry lobbied government against improving their protection for breastfeeding in the Maternity Protection Acts. They directly lobbied against the extended and paid breastfeeding leave because it would hurt their sales. So really, just in concluding, I would say, if you are not going forward, you will go backwards. Where you are in an enviable position globally, you cannot just sit there Because if you do not continue, you will move back. And industry, I guarantee it, are constantly strategizing about how to enter markets. You need to continue to promote and support breastfeeding. But I would say that information and education, both for health workers and families, is important, but it's not enough. You've got to do more than just information and education. There are many other effective options, and you have excellent technical people in this room. I don't need to go into those details. But breastfeeding is responsive to supportive interventions. Maternity protection in all work areas. And I neglected to put in anything about the informal economy, which is massive. In India, it represents almost 90% of all working women. They are in the informal sector, completely absent of maternity protection. In Africa, it's between 78 and 85%. It's a massive sector where these women don't have any access to support. But you also need to be thinking about the regulatory response to marketing. In every country, in every region, industry has argued for self-regulation. It has never worked. Sri Lanka has a long history of legislation to protect breastfeeding. It's admirable. You have new food labeling coming in January. You have draft breastfeeding code legislation coming up. But Dr. Daniel presented this one, that within the region, there are still vulnerabilities. There are areas where things can be better. So, for example, there have been no meaningful sanctions in Sri Lanka, but then there have been no meaningful sanctions anywhere in the world. So how is it you can have legislation, but unless there is monitoring and brave leadership to actually impose sanctions, then I think we will remain vulnerable. Thank you very much indeed.
Thank you, sir. I would like to cordially invite Dr. Susie Pereira, Deputy Director General, Public Health Services 2, to address the gathering.
Very good morning to all of you. Director General of Health Services, and all of you in the audience today. I think we are at a landmark in a transition. So although the analysis has shown us something, there is hope as well as uncertainty both. It could go either way. That is what I'm hearing, and I think you all would also take it that way. But as we are in an economic crisis, though there are these vulnerabilities, we are also at a place where we can make use of this window of an opportunity. But again, what I'm hearing is the industry can outsmart us. So this is a situation where the vulnerabilities of the mother, the sentiments are being exploited, as well as the health professionals. So two things that we have to be mindful of. So while these pieces of legislature will go through, and as Dr. Nigel quite correctly says, about the sanctions. Can we do that? But at least from this month, what I'm hearing from my colleagues in the audience, there needs to be some powerful message given to the industry as well, that they should be kept in place. As we, as professionals, also not be vulnerable to what they can offer. In this economic crisis, especially to all the institutions, whether it's professional institutions, to the hospitals, the word public-private partnership was mentioned by you, Dr. Nigel. So I think under this guise can come in some opportunity that the market may creep in and offer things in the form of a partnership, but at the same time create a market for their products. So these are the things that we have to now carefully analyze, and maybe we need to have a very short-term, intermediate-term plan how we're going to address this. So this is very, very important. It's not the legal part is there, the human resource, the education, all that is there, but we have the opportunity of a public health system, the ground network of all the mothers who are attending parent crafting and all these sessions. All of that is there, but still the market, the industry knows what sentiments they are working on. The sentiments of the mother who feels that giving a bottle something is going to make the baby sleep better or something like that. So these are the things that are going to, these myths that are going to be captured. But we also know that there is a lot that can be articulated through the complementary feeding, the weaning, all of that that has to come in the natural forms. So we have to make our program more sharp and focused. I think that's what I'm hearing from all the powerful technical discussions that have taken place. We need to revisit our program for communicating to the industry immediately, put them in their place, informing all the health professionals what the legislature, even the existing one, is strong. That is what Dr. Hiranya conveyed. About the public-private partnerships that can go in a different direction and can be dangerous because of our economic vulnerability. We know that we have lessons on ground recently, the things that have happened even with the food crisis, how there is capitalization of market in our distress, right? So this is happening, right? And let's make our public health system stronger in educating, empowering our mothers, the parents, because they access our health system. I don't want to talk much because I think we have a very good panel discussion also later on, and we must listen to our Director General Health Services, who is no doubt going to give leadership this month. It's very crucial that we must boost up our efforts. And as Deputy Director General of Public Health Services, who oversees these programs, I think different sectors, whether it's the plantations, whether it's the urban under-settlement areas, there are a lot of vulnerabilities coming in. And I'm sure the industry is nicely observing all what we are doing, and very carefully they are going to come in some way that we will not be even guessing now, right? So let's be prepared and be proactive. Thank you very much.
Thank you, Madam. May I now invite the Director General Health Services, Dr. Asela Gunawardena, to address the gathering.
Good morning to all of you. Today, the keynote speaker, Dr. Nigel Rawlings from WHO headquarters, Deputy Director General Public Health Services to Dr. Susi Perra, Director FHP Dr. Chitra Mali, and all the provincial directors, regional directors, directors of the hospitals, directors of the Ministry of Health, President College of Pediatricians, and all the other consultants, professors, and our friends of development partners, WHO and the UNICEF, and all the other ministry representatives, and PG trainees, and doctors of maternal and child health, and all the participants. Ladies and gentlemen, first of all, I would like to be proud to be here and address in this very remarkable occasion on Breastfeeding Week. And I was prepared a speech, and after hearing the few speeches, I thought it is no point again I am repeating the same thing and addressing you all. So as Professor Nigel and Dr. Susi Perra was very clearly mentioned, right? We all know we were in the most difficult period of our history, in Sri Lanka. We were down by economic crisis, and we were faced COVID-19 pandemic, and that we are running into great difficulty. But because of the great public services, still we are doing a very remarkable service to the general public as well as the curative services. So as Professor Nigel and Dr. Susi Perra mentions, these public-private partnership is coming right now. I think all of you know it's very well. Right now, one side, we are economically down and we don't have enough money. And so the other side, this help is coming. So we have to be very tactful and careful, because we all product of free education and free health service. So we have to protect this free health service, right? I think there is a real threat for our free health service right now. The things were coming up in media and all those things, it's really damaging, right? So maybe not the truth. The things are coming is on tip of the iceberg. It is not the real scenario. So I think here all the provincial directors, regional directors, and doctors of there's MOMCH, and all the public health staff is here, and all the hospital directors are here, and all the consultant pediatricians and VOGs are here. So it is our duty to protect this and run this. And I think all of us are product of breastfeeding. I think none of here were only formula fed. I think all must have breastfed, right? So it is Sri Lanka having a culture where mother is our most important person. I am not saying fathers are not important, right? So mothers are the most important in our culture, and breastfeeding is inculcated to that, right? So we have our own rich culture, and which is very supportive of breastfeeding. And I think what that Professor Rawlings has said is the commercial, I think it is right now, it's all of us. I think there are a lot of colleges here, College of Pediatrician, Janobs, Nutrition, uh, and College of Administrators, College of members of College of CCPs, Community Medicine, and all are here, right? So it is to be, take that message, right? It is not to and they are teaching. So don't let me to send letters by warning not to take advertisements from these companies. So it is our duty, have your own conscience and make it a very, very good place for people of this country and promote the breastfeeding and make our nation healthier. Thank you.
Thank you, sir. Now we have a short break for tea. Kindly be in your seats in half an hour.
Ladies and gentlemen, next we would like to display a video created to educate working mothers on expressing and storing of breast milk, developed by Health Promotion Bureau, Family Health Bureau and Sun PF.
දුව වගේම අපි හැමෝම පැටියව ආදරෙන් බලා ගන්නවා.
දරුවාගේ මුල් මාස 6ේදී පූර්ණ පෝෂණයට අවශ්‍ය එකම ආහාරය මව්කිරි. රැකියාවේ නියැලෙන මව දුවා තබා යන කිරි සෞඛ්‍ය ආරක්ෂිතව දරුවාට ලබා දෙන්නට ඇයට ආදරයෙන් සහාය වෙමු.
මව්කිරි දොවන එක, දෙව් මව්කිරි දරුවට දෙන එක මේ හැම දෙම කරන්නේ සබන් දාලා අත් සෝදලයි. කිරි දොවන්නේ හොඳින් පිරිසිදු කරගත් කට පළල් භාජනයකට. ආහාර දෙමීමට සුදුසු වීදුරු, මල නොබැදෙන වානේ හෝ ප්ලාස්ටික් භාජනයක් භාවිත කරන්න පුළුවන්. මව්කිරි දොවාගත් භාජනය හොඳින් වැසෙන පියනකින් වසන්න. දොවාගත් කිරි සෙල්සියස් අංශක 25 හෝ කාමර උෂ්ණත්වයේ උපරිමය පැය 4ක් දක්වා තියාගන්න පුළුවන්. ශීතකරණය නම් සෙල්සියස් අංශක 4ක උෂ්ණත්වයක උපරිම දින 4ක් තියාගන්න පුළුවන්. කිරි භාජනයේ දිනය වේලාව ලියලා වහලා තියන්න. දොවාගත් මව්කිරි කිසිම විටක ශීතකරණයේ දොරේ ගබඩා කරන්න එපා. මුලින් දෙවූ කිරි මුලින් දෙන එක තමයි හොඳ. ශීතකරණයේ දාපු කිරි දරුවට දෙන්න කලින් මද උණුසුම් වතුරේ කිරි බඳුන තියන්න. කාමර උෂ්ණත්වයට ආවට පස්සේ ඒ කිරි දරුවට දෙන්න පුළුවන්. දරුවට දෙන්න ඕනි. කිරි ඉතුරු වුණොත් ආයි කිරි ශීතකරණයේ දාන්න එපා. ඉවත් කරන්න.
මව්බිමේ සවිය මව් කිරින් සදන ආදරණීය අම්මලාට බෙහෙවින්ම ස්තුතියි.
දුව වගේම අපි හැමෝම පැටියව ආදරෙන් බලා ගන්නවා.
දරුවාගේ මුල් මාස 6ේදී පූර්ණ පෝෂණයට අවශ්‍ය එකම රැකියාවේ නියැලෙන මව දුවා තබා යන කිරි සෞඛ්‍ය ආරක්ෂිතව දරුවාට ලබා දෙන්නට ඇයට ආදරයෙන් සහාය වෙමු.
මව්කිරි දොවන එක, දෙව් මව්කිරි දරුවට දෙන එක මේ හැම දෙම කරන්නේ සබන් දාලා අත් සෝදලයි. කිරි දොවන්නේ සබන් යොදා හොඳින් පිරිසිදු කරගත් කට පළල් භාජනයකට. ආහාර දෙමීමට සුදුසු වීදුරු, මල නොබැදෙන වානේ හෝ ප්ලාස්ටික් භාජනයක් භාවිත කරන්න පුළුවන්. මව්කිරි දොවාගත් භාජනය හොඳින් වැසෙන පියනකින් වසන්න. දොවාගත් කිරි සෙල්සියස් අංශක 25 හෝ කාමර උෂ්ණත්වයේ උපරිමය පැය 4ක් දක්වා තියාගන්න පුළුවන්. ශීතකරණය නම් සෙල්සියස් අංශක 4ක උෂ්ණත්වයක උපරිම දින 4ක් තියාගන්න පුළුවන්. කිරි භාජනයේ දිනය වේලාව ලියලා වහලා තියන්න. දොවාගත් මව්කිරි කිසිම විටක ශීතකරණයේ දොරේ ගබඩා කරන්න එපා. මුලින් දෙවූ කිරි මුලින් දෙන එක තමයි හොඳ. ශීතකරණයේ දාපු කිරි දරුවට දෙන්න කලින් මද උණුසුම් වතුරේ කිරි බඳුන තියන්න. කාමර උෂ්ණත්වයට ආවට පස්සේ ඒ කිරි දරුවට දෙන්න පුළුවන්. හැබැයි පැය 2ක් ඇතුළත මේ කිරි දරුවට දෙන්න ඕනි. කිරි ඉතුරු වුණොත් ආයි ඒ කිරි ශීතකරණයේ දාන්න එපා. ඒව ඉවත් කරන්න.
මව්බිමේ සවිය මව් කිරින් සදන ආදරණීය අම්මලාට බෙහෙවින්ම ස්තුතියි.
දුව වගේම අපි හැමෝම පැටියව ආදරෙන් බලා ගන්නවා.
දරුවාගේ මුල් මාස 6ේදී පූර්ණ පෝෂණයට අවශ්‍ය එකම ආහාරය මව්කිරි. රැකියාවේ නියැලෙන මව දුවා තබා යන කිරි සෞඛ්‍ය ආරක්ෂිතව දරුවාට ලබා දෙන්නට ඇයට ආදරයෙන් සහාය වෙමු.
මව්කිරි දොවන එක, දෙව් මව්කිරි දරුවට දෙන එක මේ හැම දෙම කරන්නේ සබන් දාලා අත් සෝදලයි. කිරි දොවන්නේ සබන් යොදා හොඳින් පිරිසිදු කරගත් කට පළල් භාජනයකට. ආහාර දෙමීමට සුදුසු වීදුරු, මල නොබැදෙන වානේ හෝ ප්ලාස්ටික් භාජනයක් භාවිත කරන්න පුළුවන්. මව්කිරි දොවාගත් භාජනය හොඳින් වැසෙන පියනකින් වසන්න. දොවාගත් කිරි සෙල්සියස් අංශක 25 හෝ කාමර උෂ්ණත්වයේ උපරිමය පැය 4ක් දක්වා තියාගන්න පුළුවන්. ශීතකරණය නම් සෙල්සියස් අංශක 4ක උෂ්ණත්වයක උපරිම දින 4ක් තියාගන්න පුළුවන්. කිරිභාජනේ දිනය වෙලාව ලියලා වහලා තියන්න. දුවාගත් මව්කිරි කිසිම විටක ශීතකරණයේ දොරේ ගබඩා කරන්න එපා. මුලින් දෙවූ කිරි මුලින් දෙන එක තමයි හොඳ. ශීතකරණයේ දාපු කිරි දරුවට දෙන්න කලින් මද උණුසුම් වතුරේ කිරි බඳුන තියන්න. කාමර උෂ්ණත්වයට ආවට පස්සේ ඒ කිරි දරුවට දෙන්න පුළුවන්. හැබැයි පැය 2ක් ඇතුළත මේ කිරි දරුවට දෙන්න ඕනි. කිරි ඉතුරු වුණොත් ආයි ඒ කිරි ශීතකරණයේ දාන්න එපා. ඒව ඉවත් කරන්න.
මව්බිමේ සවිය මව්කිරින් සඳ ආදරණීය අම්මලාට බෙහෙවින්ම ස්තුතියි.
දුව වගේම අපි හැමෝම පැටියව ආදරෙන් බලා ගන්නවා.
දරුවාගේ මුල් මාස 6ේදී පූර්ණ පෝෂණයට අවශ්‍ය එකම ආහාරය මව්කිරි. රැකියාවේ නියැලෙන මව දුවා තබා යන කිරි සෞඛ්‍ය ආරක්ෂිතව දරුවාට ලබා දෙන්නට ඇයට ආදරයෙන් සහාය වෙමු.
මව්කිරි දොවන එක දෙව් මව්කිරි දරුවට දෙන එක මේ හැම දෙම කරන්නේ සබන්දා කිරි දොවන්නේ සබන් යොදා හොඳින් පිරිසිදු කරගත් කට පළල් භාජනයකට. ආහාර දෙමීමට සුදුසු වීදුරු මල නොබැතින වානේ හෝ ප්ලාස්ටික් භාජනයක් භාවිත කරන්න පුළුවන්. මව්කිරි දොවාගත් භාජනය හොඳින් වැසෙන පියනකින් වසන්න. දොවාගත් කිරි සෙල්සියස් අංශක 25 හෝ කාමර උෂ්ණත්වය 4ක් දක්වා තියාගන්න පුළුවන්. ශීතකරණය නම් සෙල්සියස් අංශක 4ක උෂ්ණත්වයක උපරිම දින 4ක් තියාගන්න පුළුවන්. කිරිභාජනේ දිනය වෙලාව ලියලා වහලා තියන්න. දොවාගත් මව්කිරි කිසිම විටක ශීතකරණයේ දොරේ ගබඩා කරන්න එපා. මුලින් දෙවූ කිරි මුලින් දෙන එක තමයි හොඳ. ශීතකරණයේ දාපු කිරි දරුවට දෙන්න කලින් මද උණුසුම් වතුරේ කිරි බඳුන තියන්න. කාමර උෂ්ණත්වයට ආවට පස්සේ ඒ කිරි දරුවට දෙන්න පුළුවන්. හැබැයි පැය 2ක් ඇතුළත මේ කිරි දරුවට දෙන්න ඕනි. කිරි ඉතුරු වුණොත් ආයි ඒ කිරි ශීතකරණයේ දාන්න එපා. ඒව ඉවත් කරන්න.
මව්බිමේ සවිය මව්කිරින් සදන ආදරණීය අම්මලාට බෙහෙවින්ම ස්තුතියි.
Yeah, I have to introduce.
Can I just put up the other presentation just so that we're ready?
Since we are running out of time, can you please take your seats? Thank you. We would be moving on to the technical session now, and I would like to cordially invite Dr. Nigel Rollins from the WHO headquarters to enlighten us on why breastfeeding is crucially important but increasingly challenged in a market-driven world.
Thank you again for the warm welcome. It's always nice to talk over tea and coffee, but I have to confess that I also needed 5 minutes just to finish the slides. It's the way that life is today. I remember you had to finish your slides, maybe 4 weeks in advance in order to send them away, and now you finished them 5 minutes before. We're going to have two different. I'm sorry for having to stand here in front of you. Two different sessions now, and in between we will have 10, 15 minutes for comments and questions. And it's always my belief that it's actually the comments and the questions where there is the greatest value. So please be ready to stand up and comment and make points. In February, 3 papers were published in The Lancet called the 2023 series on breastfeeding. And I was part of that. And so the first thing I want to do is to acknowledge my co-authors. There were 25 authors from 12 or 13 different countries, and they were wonderful to work with. They started as colleagues, and they ended up as friends. So I just really want to acknowledge their input and efforts here, because what I'm sharing is very much their work as much as mine. I also want to just comment that throughout the series we refer to commercial milk formula instead of breast milk substitutes. And this was a very deliberate decision, because we used the term to highlight the artificial and ultra-processed nature of formula products. In some countries, actually, formula does not achieve the technical qualifications and standards to be called a milk. We called it commercial milk formula because it captured the sense of it. But the other thing is that whenever we refer to the word as a substitute, it gives the impression that somehow it is equivalent, and it's not. The second thing, just marketing, is everything. It's every activity. It is not just the picture, the advertisement or whatever, or the poster, or even sponsorship. And it's not really, everybody in this room, there is such a bigger world to marketing than just that advertisement. Every time we give permission for those cookies on our phones, triggers, our data goes elsewhere. So what I'm referring to now is that the brokering, the trading of our data, our names, our email addresses, our ages, our preferences, that industry is worth $200 billion a year, just the trading of that information to the marketing companies. So this is not to do with formula, it's everything. But that's very much part of marketing as well. So I'm going to present the first of these papers, and it's titled Breastfeeding, Critically Important but Increasingly challenged in a market-driven world. And I want to present you some aspects of that paper, not all of it. This is a slide that I shared a little bit earlier, the importance of breastfeeding, things that we've all talked about. But I just want to show you a couple of other bits and pieces of information that go along in the paper. This is the slide I showed of the flat trends. But these are some of the data actually from the papers. It's a little bit hard to see from a distance, so I realize that and apologize. On the left, you will see the blue bars, and those are the rates of early initiation within 60 minutes. These data are only from low and middle income countries. Not because anybody wanted just to focus on the poorer countries. It's because there's no data from the high-income countries. High-income countries do not put a priority or a value on breastfeeding, and therefore they don't collect data. It's shocking, absolutely shocking, astonishing, but it's true. And what we see from these data from all around the low and middle income world is that fewer than half of newborns are put to the breast within the first hour of life. And I'll come back to that in the next slide. On the right-hand side, we see the consequence of that. On the x-axis, on the bottom, we see early initiation rates, the higher being to the right. What we see on the y-axis is the influence of any prelacteal feed. So where you have low levels of prelacteal feed on the y-axis, you get high prevalence of early initiation. Where you have high levels of prelacteal feed on the y-axis, you have low prevalence of early initiation. And what I don't show here are some of the differences between public and private sector. Across the hospitals and the systems that we have data from the DHS, from the Demographic Health Surveys around the world, we have data from 160 countries. We see that in the public sector, any prelacteal substance tends to be water. What we see from the private facilities is that the prelacteal tends to be formula. And this speaks to what I was saying earlier about the public-private and the commercialization, because those companies are having contracts with the private hospitals where they are promoting formula within those private sectors. And what we know from the data is that prelacteals are not only associated with delayed initiation, but they're also associated with shorter durations of breastfeeding and increased consumption of formula. It's something for us to know. We cannot let the early initiation slip. Again, I'm not going to go into lots of statistics, but this has a consequence. And the bottom line is that if a child starts within 60 minutes, and you look at their mortality compared to when infants start breastfeeding within or between 2 and 23 hours, for that child with delayed initiation, there's a 40% increased neonatal mortality rate. And whenever breastfeeding is delayed beyond 24 hours, there is a 79% increase in mortality risk. So it has a very immediate and definite consequence. Very often breastfeeding is presented as a poor country. Data are all from low resource settings. But this was an analysis published in the Lancet Americas in 2022. And again, now this is turning the data on the other way around. But what you're seeing is that in the US, whenever there is early initiation of breastfeeding, the mortality percent of what infants who are on formula. So there's a issue is that in the US, overall neonatal mortality rates are low, and therefore you don't see it as a big issue. But it has exactly the same biological effect. I'm not going to present anything more on all of those effects about diabetes and type 2 diabetes and obesity, development. We know all that. What we are seeing, however, but if you were to ask me, and if I was to ask you, how is it that breastfeeding does that? Because I'll tell you one thing, it's not because of just the protein and the carbohydrate and the micronutrients, et cetera, there's something much, much more sophisticated and elaborate going on. And what we are seeing is a lot of basic research that is helping to explain why breastfeeding has such an impact on health and development lifelong. You're never going to see this, okay? But this is what happens whenever this was right from the beginning. Because of the way that feeds are important for establishing your microbiome, and that profoundly influences your immune system. Your gut is the largest immune organ in the body. So how you feed and how you eat, and especially in the first 6 and 12 months, completely alters you in one direction or the other in terms of your immune system. Human milk oligosaccharides, we probably see these on the tins of formula, HMO. But these are the sugars that the bacteria in the gut feed on. Okay, so they're not absorbed, but they're in breast milk, and they're now being added to formula milk. In breast milk, there are over 200 HMOs, and these change on a daily basis. They're different between mother, and what's in the mother corresponds and influences the child. They're important for the bacteria, they're important for brain development. In formula milk, they add 2 HMOs to a formula milk, and they market it to say, with HMOs added, as if they were somehow replicating or coming close to breast milk. And what we are seeing is, in the basic science literature, this was a review in Science by a guy called Lars Bode, and he just described with how systems biology, so that we think about breast milk or nutrition as the protein or the carbohydrate or the micronutrient. But actually breastfeeding and breast milk influences our entire biological systems, because things don't sit in isolation. And so what we are seeing is a much greater understanding of the system and the influence of breastfeeding on it. So if you were to ask me, how do all these things happen? I know it's such a small bit, but I'm understanding that the science is deepening, that the gap between breastfeeding and, so we know the gap in terms of the health effects, but what we're also seeing now is the gap growing in terms of our understanding why. Paper 1 in the series takes a very interesting look at 1 or 2 things, and I'm just going to go through those. And it's about infant behavior. So I imagine many people in the room have children. But human babies, as you very well know, are born in an immature state. In fact, compared to all other primates, we are born in the most immature state, which means that babies are very dependent, and that after birth, there is an important period of adjustment and learning by babies. And that takes time. It takes time to learn about sleep, about learning how to feed, about learning to interact. There are different types of cries, which you know very well, but crying is a way for babies to communicate. It is not only a way of demonstrating distress. On the other side of the story, crying and regurgitation, for example, are very distressing for parents. And in a systematic review from 22 countries, all different income levels, crying's common, part of normal development, and regurgitating, at least 50% of healthy infants, no other issues, they regurgitate at least once a day. And this whole understanding of what is normal infant behavior is good for us as pediatricians to understand, and child health practitioners. Because if we don't have a good sense of what's normal, then it's easy for us to be drawn in to the concerns and anxieties. Because crying and fussiness is very worrying, especially for new parents. And it undermines confidence in just about everything. For the mother, it undermines her confidence that she's got enough milk. And health professionals and partners and families may also misinterpret that crying to say, oh, there's something wrong with your feeding. And so this takes us to what people now call self-reported insufficient milk. And that is the commonest reason. 45% of mothers who stop breastfeeding and introduce, they say it is because of this sense of insufficient milk. But what we know as well is that when health systems are able to provide effective counselling and support, it helps parents to understand those cues and to improve effective breastfeeding and breast milk production. The ball is in our court. We can do something about it. But first, we need to understand what's normal. But when we look at what we see within the shops and in the literature of the marketing world, is that they take what is an area of concern for the parent, and they start in a very clever and a very subtle way of starting to say, well, maybe something is not quite right. They do not need to do more. They do not need to prove it. All they need to do is to put the question in your head. Because every parent wants the best for their child. And if they do not understand about crying or regurgitation, they think the problem is me. And I don't want to take any risk with my child. We like certainty. And what industry does in its marketing strategies, and we see this in many, many different ways, it takes what's actually normal and it repositions it, it reframes it as possibly abnormal. If you are not sure, if your baby has a rash or regurgitates or vomits or is unsettled or not sleeping, maybe they have an allergy. And what they then do is that they offer their products as the solution. And because we are worried about our child or want the best for our child, we buy into that solution. And health workers are the same. Because if you don't know, or if I don't know what's normal, and then I'm trying to find a solution for that child and that mother. And it's quicker to actually give something like formula than to sit down for 10 or 15 minutes and work through what's actually going on. And I'll show you a piece later on where industry, this was the CEO of a formula company. He said, what we are doing is selling peace of mind. They're not selling nutrition, they are selling peace of mind. And so what we see as well in the series and in the review is that unless mothers have skilled support and reassurance, parents change from breastfeeding to formula milk, or from one formula milk to the other. So there is enormous opportunity that where the health systems, it's not just information and education. There is something about understanding behavior and providing that comfort and reassurance. The amazing thing is that breastfeeding is very responsive to interventions. All you need to do is to look at the graph on the right and you see the things going up. This was a project in Vietnam, and they saw, it was actually done in several countries, in Vietnam, Bangladesh, and also in Burkina Faso. And in all the settings, they had a combination of working with health workers, social media, but also then some of the regulations. And they found in those countries where the rates were not as high as Sri Lanka, they were able to increase breastfeeding rates within 2 years. It's not a generation that you need to wait to see an impact. Breastfeeding is very responsive to interventions. Systematic reviews tell us the same. That's all you need to know. The systematic reviews tell us exactly the same. Breastfeeding rates are very responsive. And when in the Lancet papers we looked at case studies from different places, in Burkina Faso they were creating mother-to-mother support groups. There was evidence-based social and behavior change communication. Mexico, the government were using landscape analyses. They were looking for strong position statements from the National Academy of Medicine in Mexico, like the Sri Lankan Pediatric Association. Your lead makes a difference. In the Philippines, they extended maternity leave. In the US, they were using monitoring and surveillance, and all of them work. All of them work, but they require investment. I want to just make one mention of maternity protection because this is often a blind spot. It is absolutely essential. If we are wanting for equity and empowerment, then maternity protection needs to be there across all sectors of work, not just government, but in private. And this is an area where government can legislate and require things. The big difficulty is the informal economy. But we see that there are countries who are exploring this now. And as much as this is a major investment to go out and very difficult to contemplate in a time of economic crisis, the return is there. The problem is that the return is not immediate. But this is where you've got to be brave and take that slightly longer term perspective, because where you have maternity leave, you increase early initiation rates and you increase exclusive breastfeeding rates. Or maybe in Sri Lanka, you protect what you've got. So this particular slide is not about the graphs at the bottom. It is about the figure in the top right. Because one of the things that makes a difference to the system is advocacy. It is one of the essential and critical cogs in the wheel. You need to observe everything. You need to see what's coming in through the consumer dialogue, through the things that will come in from industry, and you need to protect that as well as being continuing advocates for that. So really, in conclusion, I think the Director General said this, breastfeeding success is a collective responsibility, but it's not just Ministry of Health. It is actually across trade, across labour, across justice, civil society, because if it's not a collective responsibility, then it's seen as only the responsibility of the woman. And therefore, if something happens that she's not able to breastfeed, then she is seen to fail. And therefore, she carries the responsibility of failure, when in fact, the times that the inability to breastfeed is because the system, the health services are not providing the counselling and support. The workplace environment is not providing adequate maternity protection, because the family believes that the adverts and is putting pressure on the woman to maybe give some formula, because you see what's on the picture here. And so it is a collective responsibility. Secondly, infant behaviours, it's important for us to understand them, both to be able to support, but also to be able to refute and argue against what we see coming from industry. And that there are many constraints if a woman decides that she wants to breastfeed. It's therefore the responsibility, I think, of many people in this room, in ministries, directors of programs, directors of hospitals, to take responsibility. It isn't just government, because many of us have influence over a local facility, to actually support breastfeeding and mitigate the undermining influences we see around about us. Thanks very much.
To be interpreted in a medicalized way, so the medicalization of health. So that is what is being used very broadly by the industry to make health effects and general health issues to be framed as medical issues and offer solutions. So I think, yes, industry is using it, but for a major part, health professionals are also contributing to make things worse. For example, when a mother comes stating that she has less breast milk, sometimes the impulsive reaction from the health professionals is to give or make her stress to a higher level, which makes further reduction of breast milk and so on. So we are writing prescriptions. So I think that elements need to be really clearly addressed within the training of medical professionals. Thank you.
Thanks. I think back to, I trained a long time ago, but I can remember clearly I had no training on breastfeeding support. I remember sitting in the pediatric ward with the pediatric consultant and being given a bottle to feed to the baby in the ward. I received zero training on breastfeeding. So I think, if you look across the medical curricula, one, I think at an individual level, I don't know what I imagine things are better in Sri Lanka. But if you look globally, there is a definite deficit in training. I don't think health professionals and medical curricula are very good at training about conflict of interest, however. I don't think we see conflict of interest. I would say that if we were to have a secret survey and to say, do you think that you're influenced by marketing? I would guess 80 to 90% of us would say no. But industry spends $3.5 billion a year that it works, because it's clear it works. And I think our naivety is that we think we're not influenced by it. I would, however, say in defense of our profession, you're right that we haven't always, especially at an individual level, recognized the commercialization of health. And in fact, I'll make reference to it later. In WHO, in 2008-2009, there was a very influential report about the social determinants of health. And I'm sure many of us will think about, we know the term now, the social determinants of health, and that's influenced a lot of work and thinking and policy, etc. There's a new stream of work in WHO called the commercial determinants of health, because we are slow. We are way, way, way behind our understanding of the commercial drivers that have an impact on health, not just formula milk. And sometimes there are positive commercial factors, but very substantially there are negative effects of this commercial world where shareholder interest comes in conflict with public health. And what I think has happened is that few of us, absolutely for myself, have been able to stand back and to recognize what has been going on. We are too close. And so I think in good faith, we have talked about things where we have, but effectively we have medicalized issues which weren't really medical issues. I don't think that was only because we were somehow being influenced. I just don't think we had the vision and the eyes to recognize the landscape. But the other side of that is industry has the smartest of the strategic people around, and they play the long game. And so they are gradually able to influence the environment in that direction. And maybe some of the next presentations, I'll show you why I say that.
Thank you very much for your nice presentation, and it's a very good and eye-opening presentation. My question is, there are some international agreement from the country-wise, for example, WTO, World Trade Organization. As a nation, we like to overcome the problem. We like to promote the habit of breastfeeding, but same time as a media, health personnel, we are struggling with the worldwide agreement like WTO. How to overcome this challenge, sir?
So this is a really complicated one, because you're absolutely right that there are trade agreements. And in fact, we will know the word, the International Code of Marketing. There is another area of international regulation called Codex Alimentarius. And this is not just about formula, it's around all areas of both drug and nutrition and foods. And what industry has done, I'll make a short reference to it later, is that codex, all stakeholders can participate in the discussion and decision-making of codex. And codex sets standards around products, their quality, et cetera, but also trading. And industry has been very effective to influence codex. Now, what the World Trade Organization does is it has accepted the codex standards for how trade will be conducted between countries. And so it puts countries in a very, very difficult place. So, for example, there are several countries considering plain packaging of formula milk. None of this is to remove formula from the shelves of supermarkets. That's not what we're doing, because there are women who need formula, women who choose formula. All of this discussion is about the nature of marketing practices that influence decisions in a way that benefits shareholders. So the World Trade Organization typically works in the area of economics, and countries can sometimes be intimidated by the World Trade Organization, its procedures, and industry can actually oppose and take action against an individual country. And this type of threatening behavior is very difficult. So you get a relatively small country like Sri Lanka, and the numbers are that, the likes of Nestle or Danone or any of these, they have greater assets than Sri Lanka. I will show you a slide later where they have $316 billion between 3 or 4 of the companies together. They have assets greater than, many of the countries, by GDP ranking. So that economic power allows them to function in a way that's very scary. So your comment is absolutely right. And I think this is where we need the highest level political leadership to say this is unacceptable.
Thank you very much for a very nice, great speech, Dr. Nigel. This is, I think, during this year, as health professionals, one of the most fascinating and informative lecture we had in these forums. You have mentioned CEO of some organization had told, we did mind peace rather than information dissemination. This was, which is very fascinating to me since I'm Dr. Utpala from Health Promotion Bureau, and there are a lot of media personnel here. Api kare manasa samaga ganudenuak misaka me danuma beda harimak neveyi kiyala. You have told it too very correctly, and you have provoked promotion in government sector. So we usually give the data rather than sensitive and touching information. So would you kindly advise our media personnel, how do we have to change disseminating the messages in these mothers or the people who are going to breastfeed rather going for the milk products?
I think that's a really sort of smart comment. That I was trying to look for the other slide. So there were 2 things I was going to say. One is that I made a comment that mothers, families, communities, health workers, hospitals, your Director General, your Minister of Health, the Minister of Trade, the Minister of Labour are all targets of marketing. All of them. There will be lobbying. There will be action behind the scenes to try and influence their decisions. That is all marketing. But if I don't know how many people are in the media here, maybe you could put up your hands for a moment. We've got, I don't know how many, maybe 5, 10, 12. You are also targets of marketing. Absolutely, no question about it. They see media and the influence that you have. Your papers control what's advertised. You control what's being reported. You either come out bravely and you talk like with investigative journalism and you analyze and you report, where do the profits go? I can tell you because the Lancet paper 3, if you read it, and I'm not going to go into it today, but the revenue for the sales of formula milk in Sri Lanka do not stay in Sri Lanka. Who are the beneficiaries of the sales in Sri Lanka? The shareholders in high-income settings. Read the paper, it's there. You talk about lobbying, and you see that the lobbying in the US, the dairy industry, lobbied against WHO. In the US, lobbying is legal, but you have to have a record. So it's public record. And you see it very clearly. The formula and dairy industry lobbied against US funding to WHO. You can take your own thoughts as to why that happened. It's there, the case studies are there in the paper. So that's the first comment about the media. But I think we have a lot to learn. And maybe, could I ask that you ask that question at the end of the next presentation? Because it's a point that I make. Whenever we talk about training and so on, the words that we use are information and education. And you look at where industry works, and they have the top scientists. They use very, very good qualitative work. But they function in a different way. In marketing, they refer to, when they do their formative work, they try to identify for any product, it's not just this in formula, any product, they say the highest order emotional value. So they're trying to figure out what's the trigger, but it's at the emotional level, the behavioral level, that triggers a change in practice. They don't look at information and education because that's not where we make our decisions. And so although information and education, I had that on the previous slide, is important, it's not nearly enough. And we can certainly learn how to communicate better. But maybe we can talk about it more at the end, because I'll give you some examples, okay?
I'm Kumudini Hettiarachchi from the Sunday Times. I've covered health for a very, very long time. I have many comments to make, but I will just, shorten it. Your presentation was very interesting. But with regard to breastfeeding, I think there are 2 or 3 issues that I would like to suggest to the health ministry. We have very high levels of breastfeeding, but I don't think we have identified the categories of people who really don't breastfeed, like the cities. Now, I had my children in the city, and very soon and a lot of people say when you have a baby, breastfeeding comes naturally. Breastfeeding does not come naturally. I'm sorry, right? Because the teething, a lot of issues. So I think we really need to inform the mothers who have fallen through the system. We have a very good system. I'm a fan of the state health sector, right? But I think there are people who have fallen through, and those are the city mothers and maybe the informal sector mothers. I think we need to have specially targeted programs for them and mothers who go to the private sector. Because pediatricians themselves tell the mother to give the bottle. We know that. And another thing, we were talking about politicians, right? But it's up to our bureaucrats, our public servants who have to work in the interests of the public, who have to stand up to the politicians and to the industry. And for us as media people, if they have guidelines, if they guide us and say, don't publish this, then we as journalists could put them up to our managements. Because everyone has children, right? I mean, we are talking about across the board. And another thing is, I would actually like to plead with the medical personnel at all levels not to take sponsorships from the industry or from the pharma companies.
So whether I go, I cannot say anything other than I agree 100% with all the comments. Sponsorship is part of the international code. Health workers should not take sponsorship.
A while ago, it's not recently, there was a medical professional body at which anchor mugs were given to all the participants. So, you know, the medical professionals cannot have clay feet and then talk about other issues. And there are lots of people who are very good. I mean, it's not an overall thing, right? But I think it was about 10 or 15. I've covered health for a long time, so I know, right? Anchor mugs. Anchor is the biggest company, biggest milk company in Sri Lanka. Anchor mugs were given. So, I mean, I am so glad that you have taken the bull by the horns, and this is not said with any malice. This is said not at all, because I am a very big fan of the public health sector. Y'all are doing a great service, but there are people who are taking sponsorships.
I am absolutely certain that you're right. And I can tell you that for every story that you tell me here, I'll tell you 5 stories that are probably worse from high income settings. There's a lot of money. It's 3.5 billion. In terms of the other couple of comments, so the issue of sponsorship, there's no question. It introduces conflict of interest, and I'll show you the consequences of that in the next presentation. In terms of, I've forgotten, I should have had a bit of paper to write down the comments. The first point was that breastfeeding is not straightforward. That's absolutely true. And if you remember the concluding slide in my last presentation was that I said, we need to promote and support breastfeeding because it's not straightforward, but it's absolutely possible. You know, my wife is a nutritionist. I'm a pediatrician. We happened to have our children in South Africa. We had no family around whatsoever. And the hospital where we went to, they tried to give our kids formula. We said no, and we went home. But I tell you, that first week was really tough, you know. And then someone who was very knowledgeable in sort of counseling came and helped us just with a little bit. And after that, everything was fine. But it wasn't straightforward. But the main point is that counseling helps. Counseling can be very effective, no question. The second point about, I think you were talking about the health sector, and I agree that, but I think one of the real challenges is accountability. And this is where I think media has an important role to play, but you know, it's not just bureaucrats. I think it's government needs to be setting the framework and the standards, but I commented in the last presentation, where is the monitoring and the implementation? Where is the accountability? And just about every country, this is a deficit. And so as much as legislation is good, as much as that series in the Lancet is helpful, it will change nothing whatsoever. Because the action and change will only come whenever, not me, I can stand here and advocate, but it's the daily commitment to what is right. And in this instance, the birth of a baby should not be a business opportunity. And that's what it is at the moment. They have commercialized and medicalized the birth of a baby, that it is a business opportunity. Could I suggest that we move into the next cycle? Because we could have actually just stopped actually here, but I've got it. And let me just see if we can get across. And hopefully this will, so if you can't see this, stand up for a moment, because we're going to change to a video. It's 59 seconds. It was designed for TikTok because you can't have things more than 60 seconds, okay? But see if you can stand up and watch it if you can, okay?
Who wants to play a game? Oh, hey, Mom. Milk? Or do you want $100?
We don't have the money to invest in marketing in the way that industry does. But we have something about what is right and wrong on our side. I'm going to go through a little bit of the second paper that was published in The Lancet, okay? And then hopefully we can move into a discussion as well. And I'll try and go through this fairly quickly because I think the discussion is the good part. This is what I showed you earlier, that the sole objective of marketing is to shape our social and professional norms, values, and beliefs, because it is aiming to change practice. But what you see on the left side is something that we also learned. It is so diverse. And even what we included in the paper in February of this year is way outdated because they're thinking about their strategies for next year. We'll always be behind. But they're sophisticated. They move and they chop and change. They're able to do that, and they have a lot of money. So they play the long game. So don't be fooled by anything else. That's the 55 billion. And I said earlier that more infants are now being fed formula than ever. The two graphs I didn't describe earlier in the earlier presentation, but what you see on the top graph, or maybe we'll take the bottom graph first. These are all the 4 different categories of formula. There's standard formula, follow-on, growing up or toddler, and then the specialized. And they're all increasing. But the metric is not the dollar value or the number of tons. These are the sales per capita. So these are the number per children is all increasing. The top one is about, you can't really see the writing, but it's on the x-axis on the horizontal, it's the sales of standard formula, and then the y-axis is breastfeeding practice. Now again, these data were, we didn't have so many countries, but you see that where sales are higher on the, going further to the right on the x-axis, you have lower breastfeeding rates, and where you have lower sales, that's closer to the 0, on the left side of the x-axis, you have much higher breastfeeding rates. So they correlate. I said the name of the paper of paper 2 is Marketing of Commercial Milk Formula, a System to Capture Parents and Communities, Science and Policy. And that's quite a striking title, but I want to show you why we think it's justified. Let's just read some of these quotations. A mother from Guadalajara in Mexico. All those scientific acronyms like DHA, you don't know what it is, but it sounds cool. It's supposed to be a nutrient that goes directly to the baby's brain for stimulation. The mother in Vietnam. The benefits my baby will get? If I want to promote brain development or height or digestion, I will find the respective formula. She thought that she could pick and choose which benefits she would get by the formula. And their beliefs have been captured. The mother from Johannesburg, I actually like that premium brand. I love the color, the expensive look, the gold, it gives it that expensive taste, as if it's procured the best quality and it's something unique and different. All the formula milks are the same. They have to be by Codex standards. But she responded to the gold color and the higher price, and her values have been captured. And the lady from London, she says, we were looking online and that little advert, Brand Z, popped up. With these cookies, they must know we're looking at baby stuff, and it popped up out of nowhere. And that's the process of capture. And industry spends a lot of money on packaging. Everything about it, the color, the little scientific symbol, the name, the little extra words for premium babies. Well, I want my baby to be a premium baby. I think my baby's a premium baby. Therefore, I will spend more because this is for premium babies. And the language on it, specially formulated for babies with gas or colic or crying, they know all the words of comfort that parents are reacting to. The baby with the glasses, going to be smarter, quicker. They know what parents want. And so what they exploit are both the anxieties and also the aspirations. And here you see it, these were all from China, but these are actual adverts, and you see the DHA. Now, it wouldn't even been in Chinese script, but it's European English, so that has some value to it. The baby who's the professor, you see the light bulb on the board. They communicate, and yet the systematic reviews show that none of these things, the polyunsaturated fatty acids, the DHA, none of them have an evidence base to say that the addition of these things to formula have any impact on health outcomes. So DHA and polyunsaturated fatty acids are important in brain development, but the addition of these things to formula milk have no proven or any benefit. But they put them on the tin, they make the claim. What is this advert selling? What's it appealing? What's it highlighting? The mother is exhausted. And what it's actually selling is sleep. What do you think that